Good morning to all of you. A warm welcome to our Zoom webinar organized by GMO Sri Knowledge Academy. Kindly mute your microphone and turn off your camera during the presentation and use the chat box to clear your doubts at the end of the session. Now it's my pleasure to introduce Dr. Prabhat Kumarasinghe, Consultant General and Hepatobiliary Surgeon, currently attached to National Hospital Sri Lanka, and his lecture is going to be on patient with PR bleeding. Over to you, sir.
Thank you, Chandrika. Good morning, everyone. First, I would like to thank GMO History Knowledge Academy for giving me this opportunity to speak on a surgical topic. So today I'm gonna speak about rectal bleeding. Uh, so before talking on rectal bleeding, I thought that I should give an overview on lower GI bleeding so that you can have a better understanding. So so if you take lower GI bleeding, annual incidence is about 20 to 27 cases per 100,000 population. So, and most of the patients, they don't seek medical attention. Like mostly the patients who are having fissures, hemorrhoids, which are not troublesome, they won't come for medical checkups. So it is one of the causes for hospital admissions, and it carries a significant mortality of about 10 to 20%. Uh, so when we classify GI bleeding, so mostly it's occult lower GI bleeding, so that you can detect only on patients who are anemic and having hypochromic microcytic anemia, or patients with fecal occult blood positive. Then the other two groups are more evident, who presents with moderate to severe GI bleeding. So hematochezia is one of the conditions where upper GI causing severe bleeding, that it presents as PR bleeding. And the importance of this is that it has a very significant mortality, about 20%. And especially this occurs in elderly who are more than 65 years old. So how are we define lower GI bleeding? So anatomically, uh, fourth part of the duodenum attached to the upper jejunum at ligament of Treitz. So any bleeding occurs beyond ligament of Treitz is called lower GI bleeding. So this include small bowel bleeding, colonic bleeding, as well as rectal bleeding. Uh, Peculiar thing about small bowel bleeding is that it's obscure and difficult to localize. So when we're talking about lower GI bleeding, we should keep in mind that upper GI bleeding is also a cause for lower GI bleeding. About say most of the time, 85% of the time, lower GI bleeding is a cause beyond the ligament of Treitz, but about 15 to 10% of the time, it may be a cause above the ligament of Treitz, mostly a perforated, mostly a bleeding duodenal ulcer. So when a patient comes to a GP clinic or um, expressing that they have PR bleeding, so what we should do in examination is mainly to do abdominal examination to find any obvious masses, and do a digital examination of the rectum. So mostly low rectal tumors and low rectal pathologies are palpable to a digital examination, digital rectal examination. And as a baseline test, we can do a full blood count to assess the degree of bleeding. So should we do a tumor markers like carcinoembryonic antigen in patients with rectal bleeding? So evidence says that there's no point doing a tumor markers in a patient with PR bleeding to diagnose a disease. So unless you suspect a tumor, there's no point doing a CEA at acute admissions. And other thing is, which is obvious, that patient coming with obvious PR bleeding, there's no point of doing a fecal local blood test. So if a young patient comes with PR bleeding, abdominal pain, history of fever, mucus discharge, we have to always think of inflammatory bowel disease. So if we are suspecting inflammatory bowel disease, we can do a fecal calprotectin level. So if the fecal calprotectin is positive, in subsequent colonoscopy, finding this patient having inflammatory bowel disease is high. So it has a high positive predictive value. So at a GP setting, we can do a proctoscopy, and as a screening. But only thing is that we have to remember, even though we do a proctoscopy, we should substitute this. We should send these patients for flexible sigmoidoscopy, because a proctoscopy cannot substitute a flexible sigmoidoscopy. So why do we do a flexible sigmoidoscopy? Is that now, if you look at the colonic cancers, about 2/3 of the cancers occur in the left side of the colon. So, in the history, what are the red flag signs? So, when a patient comes with PR bleeding, if they have these 4 or 5 signs and symptoms, that you have to be bit cautious, because this may be a presentation of a more sinister pathology like cancer. So, if a patient comes with PR bleeding with alteration of bowel habits, especially diarrhea, and increased frequency, and PR bleeding associated with significant anemia, weight loss, or abdominal or rectal masses, should be taken serious. So these are called red flag signs. So any patient who comes with PR bleeding meets following criteria should be referred urgently for a specialist for further assessment. So if a patient age more than 40 years coming with alteration of bowel habits, as I told you before, like and symptoms last for 6 weeks or more, or 60-year-old patient coming with rectal bleeding, even without change of bowel habits, should be referred to a surgical specialist for further assessment. And finding of rectal bleeding with a palpable rectal mass is obviously a significant finding. So the other patients who need urgent referral is uh, patients with strong family history of colorectal malignancy, uh, and who are very anxious about colorectal cancers. And if the patient who had hemorrhoids, and still there's persistent bleeding, they should be referred for further assessment. And patients who had previous pelvic radiotherapy or suspected inflammatory bowel disease should be subjected to further assessments. So usually patients less than 45 years, flexible sigmoidoscopy is enough to assess for rectal bleeding. But patients who has family history of colorectal cancer, we should do a colonoscopy. So, according to British Society of Gastroenterology guidelines, BSG guidelines, so this is about the asymptomatic patients with positive family history. So now I'm talking about asymptomatic patients with positive family history. So if there's one first degree family member with diagnosed colorectal cancer, so at the age of 55 or more, we have to do a screening colonoscopy. But if there are 2 or more first degree relatives in the family, then the age that we should do colonoscopy is around less than 50 years. So as I told you before, if it is less than 45 years, flexible sigmoidoscopy is enough. But if it is more than 45 years coming with rectal bleeding, full colonoscopy is beneficial. And there are other group of patients who are frail and unfit for colonoscopy, because it's kind of a major procedure and it has associated complication. It needs sedation. uh, the investigation that we can order for these kind of patients is CT colonography. Now, historically, we did barium enemas for to screening, but it's no longer recommended because it has a significant misrate. So here, this is a rough guide for general population screening for for any rectal GI pathology. So what we can do is we can do fecal occult blood yearly, or every 2 yearly, from age 50 to 75. So or we can do 5 yearly sigmoidoscopy from age of 50. So these are the kind of screening guidance that you can use to assess general population. So what are the common causes for lower GI bleeding? So common causes include, the most common one is diverticulosis, and then there are anorectal disease, which includes fissures and hemorrhoids and proctitis and other things, and ischemia, inflammatory bowel disease, neoplasia, and AV malformations are the causes that would comes up to low GI bleeding. So what is diverticulosis? Diverticulosis is the commonest cause for low GI bleeding. So it's interesting that after age of 60 years, around 50% of people have evidence of radiological evidence of diverticulosis, but all of these are not symptomatic. So out of these, very little amount, about 10 to 20%, become symptomatic. The commonest side is the left colon, and in mainly in developed countries, diverticuli are more seen in left colon because their diet is like they are low fiber diet in developed countries, so that's why they have more left-sided colonic diverticuli. So out of these, 20% develop bleeding. So if we compare the left side and right side diverticuli, right side diverticuli bleeds commonly, about 50 to 90%. The reason behind this is that on the right side diverticuli, they have a broad base and their dome is big. So there's a big gap between the diverticuli and the penetrating vessel, so they tend to bleed more. So most of the patients bleeding stops spontaneous, but 5% can have catastrophic bleeding. So what is the characteristics of bleeding is that usually it's painless, but it can be associated with abdominal pain if there's overlying diverticulitis as well. It's sudden onset, it's classically maroon color, and 80% of the time it settles spontaneously, and 1/3 will repeat. So the second category is anorectal disease, mainly hemorrhoids and anal fissures. These are very common, and I would talk about this at the latter part of the lecture, so I can give more details on this. Then bit about mesenteric ischemia. So mesenteric ischemia occurs either it's embolic, thrombotic, or non-occlusive in nature. So especially commonly affects superior mesenteric artery, but it has to affect, as we all know, the blood supply of the colon and small bowel. It's supplied by superior mesenteric, inferior mesenteric, and celiac axis. So at least two or more, two vessels should be affected to have symptoms. So the main risk factors are cardiac disease and atherosclerosis for acute mesenteric ischemia. And then there are another entity called NOMI, is happens in critical ill patients who are on vasopressors. And venous thrombosis, superior mesenteric vein thrombosis, can cause intestinal swelling, and later on it can develop into bleeding. So ischemic colitis is also uh, 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 another entity where the blood supply to the colon is impaired, and it can be gangrenous or non-gangrenous, or acute or transient. and commonly the left colon is involved because blood supply to the left colon is less. That is why it's commonly involved. So what happens is when the blood supply is less, then mucosa become necrotic and it bleeds. So this is also another cause for lower GI bleeding. So then a bit about inflammatory bowel disease. So it's mainly Crohn's and ulcerative colitis. So this is usually happen in uh, younger population, presents with abdominal crampy abdominal pain, and mucus and blood and mucus diarrhea. So as we all know, the Crohn's disease mainly affects this distal ileum and the cecum, and it can affect from all drainers, but commonest area is about 40% affects the cecum and terminal ileum, and ulcerative colitis commonly affects the rectum. So then another cause is that more sinister cause is the colonic cancers and rectal cancers. Uh, then bit about AV malformations and angiodysplasia. So AV malformations these are mainly congenital and they occur in colonic submucosa, and with trauma they can bleed. But angiodysplasia is like previously healthy vessels, later on they degenerate and become ectatic, and they can bleed. 75% of the time, angiodysplasia causes cases involve the right colon, and it is one of the significant causes for small intestinal bleeds. So how are you going to work up a patient coming with moderate to severe bleeding? So this you don't see it at GP setup. So these patients straight away come to hospital. So they are critically ill. You need a basic resuscitation, uh, and then we have to rule out any upper GI causes for uh, these lower GI bleeding. As I told you, about 15% of the time, it's a upper GI cause which causes this lower GI bleeding. So easiest way is to put a NG tube and aspirate and see whether there's blood in the NG tube. So from that we can rule out any upper GI cause. So what are the other investigations that can be done? So in a stable patient, the best way is to do best method is to do a colonoscopy. But practically, it's quite difficult to do a colonoscopy in a bleeding patient, and but with the experienced endoscopist can achieve about can identify the cause of bleeding in about 70 to 80% of the time. So the importance of doing a colonoscopy is that you can identify the source of bleeding, as well as you can do curative management like application of clips, epinephrine injection, and APC. So there's an interesting study by intercollegiate guidelines. They have said that in a randomized controlled trial, so if you do a colonoscopy within 8 hours of bleeding, uh, it has not improved the survival. But if you prepare a patient properly and do it within 48 hours, you can easily identify the source of bleeding and address it properly. So what are the radiological imaging techniques, which includes nuclear scintigraphy and mesenteric angiography? So nuclear scintigraphy is that you give radio labeled you assess the bleeding by giving a radio labeled material. So this can't localize where the bleeding is. It can give a rough idea. Say when you do a nuclear scintigraphy, you can identify whether it's bleeding from left colon or right colon, and it is not therapeutic as well. So to identify in nuclear scintigraphy, bleeding rate should be 0.1 to 0.5 cc per minute, and the specificity is less. It's about 50%. So disadvantage, as I told you before, that you can't intervene, and it gives only a rough idea about the uh, site of bleeding. Then a bit about angiography. So to do a mesenteric angiography, you need the patient should bleed at least minimum bleed of 0.5 cc per minute to identify localize the place of bleeding. So importance of this mesenteric angiography is that you can identify where it bleeds, and at the same time you can put coils or you can inject vasopressin and stop the bleeding source. So most commonly, the commonest is the superior mesenteric artery. Then you would examine the inferior mesenteric artery. Then lastly, the celiac trunk. So as I told you before, it has a low sensitivity, and it has a significant morbidity as well. So ultimately, the if all these measures fail, then the patient is subjected to surgical intervention. So emergency surgery is needed in about 20% of patients. Uh, Problem with emergency surgery is that now you have done a lot of investigations, but still you couldn't localize where the bleeding is. So when you open up also, it's very difficult to identify where it bleeds, because the whole colon and the small bowel contains blood. So for that, what you can do is, once you open up, you can do a intraoperative uh, enteroscopy. You can do a small enterotomy at the colon or the small bowel, and put a scope inside and try to identify where the bleeding is. Now no longer blind colectomies are recommended, but in cases where there's evident that the blood is limited only to colon, and you can go ahead with a subtotal colectomy. So now, when we are taking a patient to emergency surgery, so how are we going to decide who needs emergency surgery or who can wait? So there's a rough guide. If you need more than 6 units of blood per 24 hours, this patient is still bleeding, they needs emergency surgery. So if a patient needs more than 10 units of blood within 24 hours, they have a very poor outcome compared to patient who needs uh, less than 10 units of blood, and it is 45 versus 7%. So as I told you before, segmental colonic resections are preferred if we can identify where the bleeding is. But in the cases of that uncertainty and bleeding is limited to colon, subtotal colectomy can be done. So bit about obscure bleeding. So obscure bleeding is defined as that when you have done a lower GI and upper GI, but still you can't find a cause, it's mainly obscure. So it's mainly the area that difficult to assess is the small bowel. So how are we going to assess small bowel is that you can use wireless capsular endoscopy. Uh, and you can do double balloon enteroscopy. So since now the capsule endoscopy is gaining more popularity over double balloon enteroscopy because it's difficult to perform. So most common causes for this obscure bleeding are angiodysplasias of small bowel, and carcinoid tumors are the most common causes. Then coming to anorectal disease. So this is one of the more common causes for PR bleeding. So main two anorectal disease are hemorrhoids and anal fissures. So I'll talk about anal fissures. So these patients most commonly presents to your GP practice with classic symptoms. They complain of pain or passage of glass particles while passing stools, and it is very painful, and it it's they are like afraid to defecate because of this persistent pain. So what happens in anal fissure is there's a tear in the epithelial lining of the anal canal. It's one of the most common problems encountered, and fissures can be acute, chronic, typical, or atypical. So it's one of the common causes for pain, and most commonly affects young patients about 20 to 40 years. And most of the fissures are acute in nature. Usually they resolve within 6 weeks without any treatment. So if they continue beyond 6 weeks, it's called chronic fissures. So in the history, it's bright red streaky bleeding on stools and with associated severe pain. uh, in some patients you can do a physical examination and you can see, if you put the patient on prone jackknife and separate the buttocks, you can see a linear separation in the inoderm. So 90% of the time it happens at the posterior midline, so or else you call it 6 o'clock position. So this clock positions are defined when a patient is lying supine lithotomy. So 12 o'clock is anterior, 6 o'clock is posterior. So mostly fissures are posterior midline 90% of the time, and anterior midline it's about 10% of the time. So generally resolves within 4 to 6 weeks with appropriate management. But chronic fissures, they tend to persist beyond 6 to 8 weeks. So chronic fissures, when you examine, it's can classically see a sentinel tag at the outside of the fissure, and inside there's a anal papilla, and base is in the base you can see internal sphincter fibers and edges will be rolled up. So those are the signs of a chronic fissure. So then there's a entity called atypical fissures. These atypical fissures are associated with other diseases like Crohn's disease, HIV, cancers, syphilis, and tuberculosis. So you have to have a rough idea if a patient presents with an atypical fissure. So how are you going to identify atypical fissure? Is that usually typical fissures occur at 6 o'clock and 12 o'clock position. If there are fissures which occur in other areas of the anal canal, so most likely it can be a atypical fissure. So what is the pathogenesis of fissures? So there are different theories that how a fissure occurs. So some say that it's passage of hard stools which causes trauma to rectal mucosa and uh, causes fissures. Or some say it's due to sphincter hypertonicity. But this sphincter hypertonicity may be due to fissure itself. And why it is mainly 6 o'clock and 12 o'clock position is that is called the watershed line, where the blood supply is minimal at 6 o'clock and 12 o'clock position. That's why it tends to cause fissures in those two positions. So how are you going to treat these patients? So so American Society of Colorectal Surgeons says that conservative therapy is the safest, and we have to all try first conservatively. So now there's another randomized trial comparing fiber alone diet with other treatments. Now, if you take fiber alone as a treatment for acute anal fissures, 87 of the patients get healed. So dietary modification enough only is enough in certain groups of patients. But patients who have persistent fissures more than 6 weeks, you have to uh, seek other modes of treatment. So likewise, for chronic fissures, they have done a 50 randomized control trials. So they have compared non-operative therapy for chronic anal fissures, and the healing rate was 34. So the chronic uh, anal fissures are difficult to manage. So why it is chronic fissures are difficult to manage? Because they have an inherent problem in the internal sphincter. Internal sphincter hypertonicity is the main problem in chronic fissures. So we have to treat the internal sphincter hypertonicity to tackle these kind of problems, right? So what are the topical agents that can be used for fissures? So mainly we use nitrates and calcium channel blockers, and also injectable agents like botulinum toxin can be used. So a bit about GTN, nitric. So it acts, nitric oxide acts as a muscle relaxant. So it relaxes the internal sphincter. And there's a landmark trial done in 1997. They compared GTN alone with placebo and shown that it's about 70% successful. But later on, studies says that GTN is not that successful. So anyway, GTN should be used, topical GTN should be used as a first line. After dietary modification, you can use GTN as a first line treatment. But the problem with GTN local application is that patients tend to get headache, but it's a tolerable headache. But most of the patients, about 60 to 70, can get headache. And other thing is, with the time, if you use long-term GTN, they get tachyphylaxis, and the desired effect is not there. So why G10 has a high failure rate is mainly due to the G10 causes internal sphincter relaxation, but it doesn't last long. It lasts only for 2 hours. So that is why G10 tends to fail in some instances managing fissures. So after we try with GTN, then we can introduce diltiazem 2% cream. So this can be applied twice a daily for 8 weeks, and it has ability to heal fissures which are not healed by GTN. So it has a less side effect profile and acts same as GTN, relaxing the internal sphincter. So then bit about botulinum injections. So there are several studies. So they have compared Botox with GTN, and they say that GTN is more effective. Uh, Sorry, this study says that Botox is more effective compared to GTN. So usually Botox 20 international units is injected at 3 o'clock and 9 o'clock positions, so which causes internal sphincter relaxation, and this would leads to healing of the fissure. But the disadvantage is it has high recurrence rate, and also sometimes it can cause incontinence, mainly for flatus. So, a bit about chronic fissures. As I told you before, the hallmark of chronic fissure is triad of hypertrophied internal sphincter, hypertrophied anal papilla, and external sentinel tag. So, in these patients, we can do fissurectomy, where you resect the internal papilla, skin tag, and the rolled up edges of the fissure, which would allow healing of the fissure. So, in instances where you suspect atypical fissures, HIV, Crohn's disease should be considered, and treatment of these two diseases would lead to healing of the uh, disease. So, as a summary for fissures, I can give you a treatment guideline. So, say now, if there's a fissure more than 6 weeks duration, we can give high fiber diet and stool softeners and sitz bath. So 90% of the fissures heal. But in failing that, we can try 0.2% GTN twice or thrice a week for 6 to 8 weeks. So if it fails, then we can try diltiazem. And after failing of this medical therapy, then we have to consider either Botox injection or surgery, lateral internal sphincterotomy. Yeah. So then bit about hemorrhoids. It's one of another common cause for PR bleeding, and I mean, you can't have any population studies on hemorrhoids because some patients, they don't, even though they have hemorrhoids, they won't come to hospitals. So it's underreported. So hemorrhoids, as we all know, it's these are anal cushions which dilate due to various reasons, including chronic strain and stress, and become dilated vessels, which causes bleeding. So mainly they are located in 3 o'clock, 11 o'clock, and 7 o'clock positions. And the importance of anal cushions is that they contribute to 15 to 20% of resting anal pressure. So there are internal hemorrhoids and external hemorrhoid. So you demarcate them along the dentate line. If it is beyond dentate line, it's called external hemorrhoids, and if it is proximal to dentate line, it's called internal hemorrhoids. So problem with external hemorrhoids is when they are thrombosed, it's extremely painful because it's innervated by the ectoderm from the surrounding skin. So it's very painful. So they need urgent surgery. So internal hemorrhoids, which are located proximal to dentate line, they are covered with columnar epithelium and viscerally innervated. So they are painless. So they are not sensitive to pain, touch, and temperature. So Gallagher classification classifies the degree of hemorrhoids. So first degree hemorrhoids are they are inside the inner canal, but still they bleed, but they don't prolapse. Second degree hemorrhoids prolapse, but spontaneously reduced. Third degree hemorrhoids prolapse and require manual reduction. Fourth degree hemorrhoids prolapsed and reducible. So internal hemorrhoids, they typically cause painless bleeding, and sometimes they cause tissue protrusion and mucus discharge. And if the hemorrhoids are a little bit bigger, they can feel incomplete evacuation. So usually causes bright red bleeding at the end of defecation, as we all know. So how are we going to manage these patients? So first degree and second degree hemorrhoids, we can try with non-medical management, like changing the diet into high fiber diet around 20 to 35 grams per day, and increase fluid intake, and try with some stool softeners. But this is okay for first degree or second degree hemorrhoids, but third and fourth degree hemorrhoids cannot be managed like this. So other common method of managing hemorrhoids, especially second degree and third degree hemorrhoid, is use of rubber band ligation. So we can place rubber bands, but we have to be very careful when we are placing rubber bands. If you place near the dentate line, they can get severe pain, and you have to remove the rubber band that you put. And the other problem with RBL is that they can get delayed bleeding after 5 to 7 days once the hemorrhoid sloughs off. So there are not many complications. Complications are very rare, about 0.5 to 0.8% in RBL. So mainly pain, and sometimes you can get urinary retention in the acute period, and bleeding after band slippage can occur. So, and we have to advise the patients that about after 5 to 10 days, once the hemorrhoid sloughs off, you can get secondary hemorrhage. So we have to always educate the patients about this. And other important thing is, because of this secondary hemorrhage, we have to stop patients who are on antiplatelets and anticoagulants 1 week before, because patients who are on these blood thinners are at higher risk of secondary bleeding, and it has a very good success rate, 50 to 100%. And sclerotherapy, it is initially done in 1869, and we inject 5% phenol or hypertonic saline. uh, 5 ml can be injected using a very small spinal needle. The mechanism is that we make vessels to be thrombosed and sclerosed. So at a time, as well as rubber band ligation, first we have to at least do 2 sides, not more than that, because there will be significant pain after these procedures, and this also can cause post procedure pain, urinary retention, and sepsis. uh, so it has a failure rate higher than banding. And if you take long term hemorrhoid free, uh, at 4 years only 8% is hemorrhoid free after sclerotherapy. So it is inferior to rubber band ligation. Then bit about surgical management. Surgical management either can be there are two techniques. It's called open and closed hemorrhoidectomy. There's not major difference, but it's a very minute difference. So in UK, they do Milligan open hemorrhoidectomy, which is open hemorrhoidectomy. That is where you remove the hemorrhoid complexes, leaving intervening mucosal bridges. Uh, but in closed hemorrhoidectomy or Ferguson hemorrhoidectomy, which is more popular in US, after resecting hemorrhoidal complexes, they suture the mucosa to inner skin. So the importance of closed hemorrhoidectomy is that healing is more, I mean, quicker, and the pain is less. So main complications after hemorrhoidectomy, when you advise patients after hemorrhoidectomy, their main complaint is pain. So there's evidence that use of prophylactic oral metronidazole, topical diltiazem or GTA, can cause less pain after hemorrhoidectomy. So later complications include hemorrhage, infection, and a bit of fecal incontinence if the sphincter is damaged. And most dreaded complication is a anal stenosis. So when we are doing hemorrhoidectomy, we have to be careful that we leave adequate skin bridges or mucosal bridges in between hemorrhoids. So when there are three large hemorrhoidal complexes, it's better to do subtotal or remove one or two hemorrhoidal complexes at a time and do complete the rest later on. So, a bit about Doppler guided transanal hemorrhoidal ligation. This is a technique where you put a Doppler probe inside the rectum and identify the rectal so then a bit about stapler hemorrhoidectomy. So stapler hemorrhoidectomy is said to be less painful than open hemorrhoidectomy, but where here what we do is that we use a hemorrhoidal stapler where you cut a donut or rim of tissue which containing hemorrhoids and anastomose the mucosa and submucosa with stapler. The problem with this is it has higher fissure rate, and but pain is comparatively less. So what are the common complications after any procedure is post-op pain. And if a patient presents with bleeding after hemorrhoidectomy, so first we can do some anal packing with swabs and see if it is not responding, then we have to re-anesthetize the patient and identify the bleeder and control it. So hemorrhoid crisis, we commonly say it's prolapsed thrombosed hemorrhoids. So prolapsed hemorrhoids, these patients come with severe pain, tissue necrosis, and evidence of sepsis. So they need adequate pain relief, and we have to try with stool softeners and apply warm socks or ice packs to reduce the inflammation. And we can start antibiotics as this is kind of a prolapsed hemorrhoid. And if it is not responding to medical therapy, then subtotal hemorrhoidectomy should be done. At this point now, as you can see in the picture, that the whole rectum, whole anal canal is involved. But if you resect everything, then they will develop uh, anal strictures later on. So subtotal hemorrhoidectomy is preferred in these instances. And other important thing is about rectal varices, because if we misinterpret hemorrhoids as rectal varices, they can bleed a lot, and even catastrophic bleeding can occur and patients can die. So it's difficult to differentiate rectal varices from hemorrhoids. But if you take up history, use of alcohol, and other signs of liver disease, you can easily diagnose. So the treatment for this rectal varices is reduction of portal hypertension. So it's form of transcapular intrahepatic portosystemic shunts or portocaval shunts. The best treatment is liver transplantation. But in case of bleeding, we can uh, do a direct suture ligation at some instances. So this is a picture of a rectal varices. It's difficult to identify from a hemorrhoid. So a bit about pregnancy and hemorrhoids. So it's they get hemorrhoids mainly due to increased intra-abdominal pressure, dehydration, constipation, and they rarely need surgical treatment during pregnancy. And we have to be very careful if we apply rubber bands or other means of treatment in these patients, it can induce labor. and can go into urinary retention. So it's better to manage conservatively. And if they persist beyond the pregnancy, then we can address it later on. And a bit about radiation proctitis. This is mainly patients who had pelvic radiotherapy. They tend to bleed a lot, and it's troublesome bleeding. It can happen throughout the day, and mainly main modes of treatment are rectal supralfate and argon plasma coagulation. Thank you. That's about it about the causes for rectal bleeding. If there are any questions, I'm happy to answer.
Thank you very much, sir, for that informative presentation. It's time to enlighten few queries. Please write your questions clearly in the chat box. We have one question, sir. Can Botox cause insufficiency of external sphincter as well?
Very unlikely. It's usually because it is mainly injected to the internal sphincter. Uh, but it depends on the person who inject. But if you carefully inject, it doesn't cause external sphincter incontinence. But it can cause incontinence of hiatus.
Does Euphoria prostata extract, brand name sitcom, show any benefit against hemorrhoids?
Well, that I have to refer. I don't know. Well, yeah, I think I would answer that question after referring. I don't know.
How to prepare a patient for an occult blood test?
Yeah. So usually preparation is you have to prepare patients over 3 days. So should avoid iron tablets and should not take vitamin C containing material like fruit juice, fruits, and vitamin C should be avoided, and should not eat red meat, so which contains heme. So 3 days preparation is enough, and it should be repeated twice.
If there are no more queries, I would like to thank Dr. Prabhat Kumar Singh for his excellent presentation on behalf of GMOSG Knowledge Academy. And I would like to present a token of appreciation to Dr. Prabhat Kumar Singh. Thank you very much, sir.
Thank you.
We are signing off today. Thank you for your participation. Have a good day. Stay